Hello, welcome to CARDIA, the program dedicated to the understanding of the human heart. I'm Mark McDonald along with Dr. Greg Mishkel from the Prairie Heart Institute, and anybody who thought maybe that Dr. Mishkel was more of a television personality than a working doctor, we can dispute that today because you're here in scrubs because you were on call all night and you came in your off hour.
I grabbed my razor and shaved, and that was it.
You've had a long day already.
It was a long day.
Yeah. Well, you know, a couple of months ago, Dr. Mishkel brought to my attention one of his patients who also had a long day, a Springfield man who had suffered a stroke. Through the good judgment of his wife, went to St. John's Hospital to the emergency room there, and actually had his life, maybe his quality of life, saved through quick action.
And I think, as we'll hear, you know, it's a nice demonstration of public education, which is people realizing that we're now treating strokes like heart attacks. We call them brain attacks now, so you got to get to the hospital fast, and you have to educate the public. The second thing is that there's a program set up to treat patients with stroke in a systematic fashion. So he received the prompt administration of a life-saving drug, or certainly a quality of life-saving drug in this situation, after having been assessed by ER doctors and neurologists and having a CAT scan, and then had the best outcome possible in that he was rendered completely asymptomatic and his disability disappeared. And then finally was fortunate enough to have found a potential cause for the stroke in the first place, which we subsequently went on to fix.
So we get to follow this patient from his description of his symptoms, clear through to the time he saw the neurologist in the emergency room, and then saw Dr. Mishkel again in the Cath lab. Let's pick it up at the beginning. Brad Swanson, it was only about, as we stand here, it was only about a month ago that you came here to the St. John's Emergency Department. And at the urging of your wife, she was with you because she thought that you might be having a stroke. What did you think?
I didn't know. I've never had any experience with anything like this before in my life. But I've had colds, very few. I never have a headache. My health is generally excellent. So when something happens, then I'm very aware of it. And all of a sudden there was a little dizziness that began. And I had to grab the wall. I had to hold the wall for just a second, you know, to steady myself. And I said, oh, this is unusual. I said, but I shook it off. I said, you know, as we age, things happen. As you know, you get up in the morning and it's always something new, and you get past a certain age. I walked to the living room where my wife was waiting for me. We were about to take a day trip, and I said, you know, I've got to sit down again. I said, I'm really dizzy, and I sat down, and then I said, my left arm. So the left arm is going numb. And then I stood up, and there was just kind of a disconnect. Things just weren't right. I knew that there was something going on. So my wife said, you know, she said, before we take this trip, let's maybe just stop by the ER. And I didn't argue with her because I knew that she was probably right. We came in here, and it was just amazing. We walked in, you know, described the symptoms, and it wasn't 30 seconds before somebody was there. They had me in a wheelchair, wheeled me into this room. There was a crew waiting for me. There were 5 people in here, all set to deal with my stroke or heart attack or whatever it was. They quickly diagnosed what it was. We had CAT scans, and I was able to receive this shot, this, I guess they call it a TPA, which is the clot buster drug. And once that was administered, the symptoms all sort of disappeared. It was accompanied, not only did I didn't realize it, but I was losing all the peripheral vision in my left eye. It was all gone. And the doctors were holding up fingers left and right. They were moving closer. And I just couldn't see that out of my left eye. So it was just another one of the symptoms of the stroke as it was happening.
Dr. Steve Evans, as the neurologist that treated Brad Swanson, he came in with some numbness in his arm, some dizziness, and some, I guess, some orientation problems. There are other indications of stroke as well, but besides that, what are common indications that a person might be having a stroke?
Well, Mr. Swanson had the symptoms you mentioned, and he also had not just disorientation, but loss of vision on one side of space. So he didn't see to the left very well. Could see things to the right, but couldn't see things to the left. That's one of the common symptoms of stroke, too, is loss of vision on one side. He had that as the outstanding symptom. Now, most people have that as part of a more severe, extensive syndrome, including things like paralysis on one side of the body or weakness on one side of the body, numbness and loss of feeling on one side of the body. Certain kinds of thinking abnormality if you have a problem with the right side of the brain, or trouble talking and understanding words and using words if it affects the left side of the brain. So those are the big ones. Loss of feeling, loss of motor function, meaning weakness, trouble with language or visual problems. Sometimes other symptoms like you mentioned, dizziness, which can be kind of nonspecific, but often is a stroke symptom too.
They would check me every 15 minutes because there's a certain danger in this drug, I guess. It's a powerful drug. It does a wonderful job. But every 15 minutes they would be in and they would put their fingers up and they said, okay, hold on to my fingers, okay, and squeeze as hard as you can. And I knew that in the right hand that I could squeeze hard, but I could tell that I just couldn't, there was not any power, any strength in my left arm. They would push down. I didn't have any problem with the lower extremities. That seemed to be okay, but definitely in my arm there was a problem. So they knew approximately where the stroke was, and then, of course, then they did the MRI and determined exactly where it was. So.
Now, it's important from your point of view to get moving on tests quickly if somebody thinks they're having a stroke. They come to the emergency room, there's a possibility it's a stroke. Why is it so important to act quickly?
It's important these days because about 9 years ago we had a new drug come on the market for use in stroke that proved to be useful in stroke, called tissue plasminogen activator. This is a protein that's naturally found in the body, and it breaks up blood clots. We use it as a drug, we give it in large amounts, and use it as a drug, and it breaks up the blood clots that cause stroke. Unfortunately, though, you have to give it pretty quickly. The brain is very sensitive to lack of blood flow, and if you don't give it quickly, then the brain dies, and even if you do break up the clot, then the brain is still damaged as a consequence of the stroke. So you really need to give it preferably within 3 hours of onset of symptoms, but at the very latest within 4.5 hours. There was a recent study that came out only a few months ago indicating that some patients could get the drug as late as 4.5 hours and still benefit. But in general, the earlier you get the drug, the better. If you get it within 90 minutes, that's better than 3 hours.
Okay, so let's take a look at this normal head of Mr. Swanson's here.
Okay, well, you kind of get the idea here, which is, I'll go to the bottom images. This is the very lowest image. This is him lying on the gantry of the CAT scanner. This is an image of his skull, nose in front. You can see his dental work and teeth here. And what the scan does is start here and then go up this way, getting cuts through the brain.
It sort of slices it in.
It slices the brain into thin sections.
Wow.
The thin sections of brain, this is the very first cut here. At this level, you can see several things. His maxillary sinuses, his nose, a little bit of the ear cartilages. But the important part for our stroke diagnosis is the nervous system, and this area is spinal cord. If we go up, we're beginning to see brain here, the lower part of brain, the cerebellum at that point. If we go higher, we see the cerebellum, the part of brain that controls coordination, and the pons of brain, one part of the brain stem it's called. If we go still higher, we see midbrain, cerebellum, frontal lobe, temporal lobe. If we go still higher, we see the area of brain that would be causing his symptoms. His outstanding symptom he had was loss of vision to the left. That's commonly produced by occlusion of an artery called the posterior cerebral artery that feeds this area of brain here. This is the visual area of brain. And a stroke here would produce inability to see things to the left side. So he was having dysfunction of this area of brain clinically.
And you're not seeing anything on the picture
But
that
the
shows
CAT scan
that.
looks fine. No,
Okay,
the
good.
anatomy looks fine, but his symptoms say there's a problem right there. In fact, his symptoms are so distinctive, it's quite certain he was having a problem right there. The fact that his CAT scan didn't show it, in the area I was pointing to on the CAT scan, there's a little spot that indicates there's some minor abnormality there. It's not a big stroke of this whole area. It's a little spot that's too bright, that's present on the side affected by his clot, but not present on the other side. So the conclusion is that although his symptoms got completely better, there was at least transiently some damage that was detectable on an imaging study.
Well, doctor, I'm intrigued by this spot, though. This is called diffusion-weighted something.
Correct. This particular MRI sequence, there's many sequences on this board here that show somewhat different things about the brain. This sequence is one called diffusion-weighted imaging. What it shows is the mobility of water molecules in the brain tissue. Damage to brain tissue generally causes water molecules to not spread through the tissue so quickly. If you have a stroke, the stroke swells a bit, the tissue gets closer, water is trapped, let's say, more inside the cells than out, and so water spreads more slowly in the damaged area. And this particular MRI sequence shows that inability of water molecules to diffuse as well as they usually did. It doesn't exactly equal stroke, but most of the cases we see are people who have diffusion-weighted imaging abnormalities. Most of the cases we see are people who've had some brain damage due to stroke. Not necessarily permanent brain damage, and I don't think it was the case in Mr. Swanson, but it indicated that there was some, at least temporary effect of the stroke, or the brain ischemia, that we could detect on an imaging study. In fact, this is the only imaging study that showed any abnormality, is this little spot right here. I don't think it necessarily shows permanent brain damage, but it shows some, at least transient brain abnormality, and it's the only thing that was abnormal on his tests.
How long did they have to keep you here to observe you, or did they let you go home the same day, or how did that happen?
Oh, no. I came in on a Friday morning, and I was released on Sunday afternoon. So it was just observation after that. I wanted to make sure that any of the symptoms that I was displaying earlier didn't return, that everything they had done was okay. And as I said, there are certain dangers in that, you know, and they wanted to make sure that I was okay before they let me out of here.
And now 1 month later, how do you feel?
Unbelievable. I mean, I would have never known that I had the stroke. There are no symptoms, nothing like I had before. It's just, it was, in my case, a miracle. You know, I've never been in the hospital before, so this was something that they told me was, you know, could have really affected my life in a very negative way for a long time. And so Dr. Evans stood at the bedside as we were talking this and getting ready for that shot, evaluating me, and he said, "If I were you, Brad," he said, "I would take that shot." And I said, "Okay, let's go, we'll do it." So it was just amazing that it could work as fast as it did. And you know, you don't know this. You don't know the ramifications. You don't know how bad it is when you're laying there and you're first admitted, because it's kind of a whirlwind of activity. But later on, you hear about other people who have had similar symptoms, or you read about, you know, the effects of stroke and how bad it could have been. So I was very lucky. You're right.
But Brad's not out of the woods yet, because like you said, you were able to find what the probable cause of his stroke was.
Well, and probable's the key word here, because you can't be 100% for sure that it was this slit-like defect or little hole in the heart that was the culprit here. There was a lot of circumstantial evidence that pointed to it, and we didn't have a lot of good reasons otherwise that he would have had a stroke, but we weren't 100% for sure that this was the culprit. So we had to make the decision that based on circumstantial evidence and common sense that closing this slit-like hole would further reduce his risk of stroke, but also with the knowledge that, frankly, staying on the medications, in particular the blood thinners, Coumadin, which itself can be problematic over the long term, that would also be an alternative. So a lot of thought and teeth gnashing went into making the final decision to close the hole.
Okay, now what we're going to pick up this tape in the cath lab. You're doing a procedure to close a hole in Brad's heart because you think that maybe the clot that caused the stroke may have been thrown because there's this hole in the heart.
Well, it was one of two scenarios. Either he had formed a clot in his body, and as we age, we are much more likely to form clots in our body, and then through a bad luck or happenstance, that clot went across the whole of his heart in a direction it shouldn't have gone in. And even something as small as a grain of sand, if it lodges in the brain, can really create a devastating effect. So that was one possibility. The other possibility was that because of the long slit-like tunnel, a clot actually would have formed within the tunnel itself and gone to the brain. So there were a number of possibilities, but again, circumstantial evidence, and ultimately we decided to close the hole.
Also, in this procedure, we'll hear reference to bubbles.
Correct.
That you're putting bubbles into his heart.
Well, part of the physiology of this is the fact that blood or clot can traverse in an inappropriate direction, in a direction it shouldn't travel in, and that's from the right circulation to the left circulation. And so we reproduce that by putting agitated saline into the patient's heart and then demonstrating that the bubbles can traverse this slit-like hole. And of course, once we close the device, or we close the hole and put a device in, we also want to then demonstrate that now there cannot be any transit of bubbles. And so we do bubble studies both before and after, and they provide sort of dramatic evidence of a treatment effect.
Okay. Our next step is the cath lab. So let's pick up the procedure there.
So Dr. Goswami is putting a catheter, which we call an ice catheter. Looks like it's in the liver. He's putting an ice catheter up into the heart. There's the catheter there. It's just butting up against, trying to get into the heart. We may need to make some adjustments here. So we see we're injecting bubbles up into this chamber here, and we can see just a ton of bubbles in the other side of the heart. They shouldn't be there. None of these bubbles should be on this side of the heart. There's a communication in his heart up in this area here. In fact, you can even see this little negative contrast jet right there. That's unopacified black blood going across that little hole that the bubbles are crossing this direction. So this wire has found its way across the hole. We're putting a catheter up across the hole into the left side of the heart, like there. We'll just confirm our position. Okay, we're going to come over here to the table. We're going to take our device. This is our little pop rivet device. This is going to get attached to this cable, and we're going to put this device into the body, and each wing is going to be on one side of the intra-atrial septum. So what we want to need to do is we have to load this device into this loading tube here. Maybe the hardest part of the procedure, hard to know. There we go. Okay, and then underwater, we pull this back. And then we want to make sure there are no bubbles. Yeah, so we recharge. pretty good. One more. One more, right, I just... What we're doing here is just making sure all the bubbles are out of the system here. It looks good. Okay. So this is ready to go into the body now. So we know that we have disc on both sides of the septum. You can see the disc on the top, and you can see the disc on the bottom, and you can see the tissue of the heart sandwiched in between. So that looks good. And it looks like it's splayed around the aorta. Almost, so we're in the right position, that's for sure. I'm going to now release the disc.
Yeah.
And now go ahead and just film up there.
Mm-hmm.
And the disc is free. Good. That looks very good. So let's go ahead and do an angiogram here and a bubble study, and then we're done. So we're going to inject some bubbles here, Mark. And this time, we don't see any bubbles on the other side. Let's do one more. Need a little bit more solution. You'll see if you can get a... We are seeing the two discs on either side of that atrial septum, and you can see that the tissue is just sandwiched between. I'm going to inject bubbles. You're going to see them at the top. There are the bubbles, and we don't see any bubbles crossing. That is perfect. We are done.
We expect nothing less than
Okay, so Mark, what we have here is this is the left atrium. We'll finish the procedure, so we don't worry about sterility. The left atrium's on top, sorry, the right atrium's on top here. The left atrium is on the bottom here. Here's the intraatrial septum. And you can actually see tissue flopping in between here. And there's a disc on top and a disc on bottom. And now we're going to inject the bubbles. And what you'll see a whole bunch of bubbles come in here. And whereas before we had bubbles coming across, these bubbles are not there. So this is a complete closure of what turned out to be a patent foraminovalle, which is a slit in the intraatrial septum. And he also had, that we didn't realize on the transesophageal echo, actually had a little hole right here as well. And this has just sealed everything off.
Okay, so you found a problem you didn't anticipate, and this one device took care of both problems.
Correct, right. He had a slit kind of going from here to here like that, and then he had a little hole there as well. And this device just sort of sandwiches everything together.
Great.
That's good.
Thanks. Well, Brad Swanson joins us in the studio now. It's been quite a couple of months, hasn't it, Brad?
It has been an interesting ride, I'll say that. Yeah.
You know, we looked at your cath lab procedure. Dr. Mishkel said it was a wonderful outcome, and I assume that means you're feeling good.
You know, when I think of what the ramifications of what I had was, you know, where I was going with this, and how I feel today, I mean, I feel as good as I did 4 months ago, 3 months ago. There's absolutely, I could go back there, from there to here,
And
no
never know
change.
nothing had happened.
Exactly, exactly. But to think about what could have happened,
Right.
whoa,
Right.
it's a big thing.
You know, you and I discussed this privately. You know, it's a good thing that you had a wife who had good sound judgment, because men tend to be a little bullheaded sometimes, and they wouldn't go to the hospital on their own. But she made sure you got there.
We were together at the time of the onset of the symptoms, and so she was the one who did say, you know, we were on our way out the door, actually. She said, just stop by the ER to check this out. And one of the physicians told me, he said that that's one of the reasons that married men live longer than single men. So glad she was there.
You know, Dr. Mishkel is in these procedures in the cath lab all the time, and he, of course, has some questions for you about your level of consciousness while you were.
Well, I'm always interested in talking to patients afterwards, you know, what they experience. What did it actually feel like to be on the other end of the sharp needle?
Interesting you would ask, because I was talking with the nurse before the anesthetic was applied, and I said, I understand that there's several levels that we can go through here. I said, there's the 1 martini, 2 martini. I said, And she said, I said, or you can, the 3 martini level. I said, well, let's go for the top one. So I was just barely conscious. There was no pain. There was, I was just barely aware. I understand some people can watch their scope on a screen. I couldn't have done that.
What about when we injected the bubbles? Did you have any?
No sensation.
No sensation.
Didn't know that at all.
Because sometimes when we inject those little micro bubbles, some people do get a funny sensation, almost like an aura, flashing lights, as the bubbles transit the hole and go to the brain. They don't stick in the brain; they break up because they're so small.
I'll be darned.
But in Brad's case, not.
No, I was completely 99% under, just barely conscious.
And you went home the next day after the cath lab procedure. When did you feel perfectly normal again?
The healing process was just in the groin there. That was all. That I felt nothing in the heart. I just assumed that there are no nerve endings there that would have caused some sensation, because there was nothing there. And just the healing from the incision was the only.
What's the prognosis for Brad now?
Well, in terms of having removed the hole as a possible culprit, we have reduced his risk to that of a man his age, but not to 0. And so he has some other risk factors for stroke that are important to acknowledge and continue to treat, and that's where his primary care physician is going to be crucial, and that is he has hypertension and has hyperlipidemia, both of which are independent risk factors for stroke. So if Brad, and he's not going to do this, but if Brad were to say, well, I'm fixed and I'm going to come off my blood pressure medications and develop hypertension that got out of control, he could have a hypertensive bleed and have a stroke, and then he would not have accrued any benefit for this procedure. Similarly, if he were not to take his cholesterol medicines or abide by an appropriate diet, and his cholesterol were to get out of control and he would build up plaque in his carotid arteries, he could have a stroke from that as well. But with respect to this particular stroke, I think his risk is back to yours or mine.
Wonderful news.
Yes, it is.
Yeah. Well, Brad, thanks for coming in. Dr. Mishkel. And we want to thank Dr. Evans as well for joining us on this program, this edition of CARDIA. And thank you for watching, too. We'll see you next time.
For a DVD copy of this episode of CARDIA, send $19.95 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, broadcast date, and topic. You may also order with your credit card by calling 800-232-3605 or by using our secure server by going online to networkknowledge.tv.